Welcome to another episode of DxTx Partners Podcast. With me today, I have the Chief Clinical Officer at DxTx, Dr. Sheel Patel, who's also the owner, lead physician at APAC Centers for Interventional Pain Management in Crown Point, Indiana, as well as in Mishawaka, Indiana. Dr. Patel, great to have you. And tell us, I already know behind you since we both are University of Michigan graduates. I love seeing the JJ McCarthy jersey behind you, but where are you joining us from today?
Yeah, good morning, Mike. Thanks for having me. I'm in Crown Point, Indiana today, which is our central location. One of our offices and one of our surgery centers is here. This is where I am 4 days out of the week.
Awesome. Just give us a background. Tell us about Sheel Patel and why you got into medicine and why did you choose interventional pain management?
Sure. This actually starts from when I was very young. I've been around interventional pain basically my entire life. My father was an anesthesiologist. He did one of the very first pain fellowships back in 1984. So when I was growing up in a small town in West Virginia, he was the only pain specialist within 80 or 90 miles. And it was something I really liked to see. The patient population is very blue collar. There's a lot of coal miners and things like that. And these people depend on their spines, to feed their families and to be able to keep shelter over their heads and all of that. And kind of what I pulled from being in his office as much as I was is he was keeping these people at work, and the gratuity, just how grateful those people were, and even the families, was something that was really powerful. So I didn't decide then and there that I wanted to be a doctor. There's no question about that. Over time, I explored everything I could. I, as you mentioned, spent 4 years in Ann Arbor, Michigan, where you can basically study anything you want. And I tried. I did my undergrad concentration in economics and Latin American studies. I did obviously the pre-med background just in case, because I always thought that that's something that I was interested in, and then eventually ended up taking the MCAT and applying for med school and doing all of that. But the original plan was always to get in on the administrative side. The original plan was to do a dual MD MBA program. And so in my junior year of college, as I started to talk to more and more people about it, they basically told me if I did that, I wouldn't be an administrator and I wouldn't be a physician. So they said, do them separately. So the advice was do the medicine first, then go back and get your MBA. So that's the process that I started. Ended up going back home to West Virginia for medical school, took the GMAT in my first year, and then it's good for 5 years. So I just took it when I had the most amount of time, because the second, third, and fourth year of med school gets very, very difficult to do anything but medicine. And so took it, had it in my back pocket, ended up my fourth year of med school, started talking to more people, applying. And then the information that I was given was, well, if you get the MD, you're still not a doctor. You need your license, so go do your internship, then go to business school. So I said, okay. So I did the match program, but just in case I didn't get into business school or I decided I wanted to practice, I did match into anesthesia as well as my intern year. During my intern year, I applied, I was in Chicago, so I applied to Northwestern and U Chicago, both great schools, got into U Chicago, did not complete the Northwestern application because, again, I was an intern. And once I got into one, I just let the other one go. And right before I had to either accept or decline, I kind of decided that maybe the clinical aspect was better for me. And so stayed in this line. Obviously, always had the interest and a lot of emphasis on the practice side, on the business side, because at the end of the day, if we can't keep our doors open, we can't help anybody. So always kind of kept that in the back of my mind in terms of how I practice medicine and how I, try to run the practice here. And so it's been very helpful, even without actually going through the program and doing the master's in business administration. So since then, completed my my residency at Rush in anesthesiology. Then I spent a year at the Cleveland Clinic for my interventional pain fellowship. Came back to Chicago and started with a group in Northwest Indiana, which was based in Munster, which is right across the border. We actually have an office now here at APAC, which is just a mile or two from that town. It's called Dyer, Indiana, which is, again, right on the border of Illinois. So been in private practice for 10 years now. Been at APAC here for, I think 4, almost 5 now. And it's great. I feel home. It's really nice to have a home. It's nice to work with a group like DxTx that allows us to do what we do well. And then the support that you guys give us on the things that we don't do well is actually even more helpful. So it's been a great journey. We get to showcase all of our skills, help lots and lots of people. And I just think we're at the process or the point now where the process is really working. Everything has become really smooth. That doesn't mean we don't have our challenges, of course, but I think what we've built over the last 4 years is really coming to fruition. And that's just as exciting as the patient outcomes that we have.
Lucky us that we were able to get you into the network. It was a fantastic catch for us. So I'm imagining the story of your father, just changing lives. One of the things that was influential for you. Was anybody else in part of that journey through your anesthesia residency, through your pain fellowship at the Cleveland Clinic, and then into the interventional pain space? Anybody else have influence in your career?
It's a great question. I've been extremely fortunate to have, I think the best mentors anybody could have in this space. As I said, I grew up in West Virginia, and everybody knows who Dr. Tim Deere is. He was 70 miles from the town that I grew up in. And so I was fortunate enough to do early rotations in med school with him. Learned obviously a ton from him. He's helped me in so many different ways as far as getting residencies, fellowships. Anytime I have a question that I really don't know where to go, he's always there to help. So he's been a phenomenal resource. In addition to that, in residency, we worked with Dr. Lubenow, Tim Lubenow, every day. He is phenomenal at what he does, and one of the, I don't want to use the word godfather, but he's one of the original, interventionalists in this field who really helped to grow stimulation and all the minimally invasive things that we do today. Then in Cleveland, Dr. Jinghua Chung, who was our program director, Michael Stanton Hicks, who is probably the godfather of CRPS, and Rick Rosenquist, who is our chairman there. Just the list goes on. And that's one of the things that we talk a lot about to our new hires is the first most important thing about your first or second job maybe is the mentorship, right? Because it doesn't matter where you do residency or where you do fellowship, the private practice world is different. And there's a lot of things that you don't have time to learn in a year, even about being a pain specialist. Forget about, all the other stuff that goes with just being a private practicing physician. And so that's what we try to do is we have new docs come in, is we really try to give them the same things that were given to us by our mentors.
That's great background. One of the things that I think is unique about you, and you've talked about just kind of that desire you have, not only are you a great physician, but you have business acumen, which is required if you're going to lead a private practice. I'd love for you to talk about kind of what you did at APAC, because I think it's unique. It was a practice that's been around for a long time. A culture had been very much entrenched, and they were underperforming. So it was a turnaround situation. Can you just share with with the people watching, what was your approach to that? How do you go in as a young physician? Don't have a lot of like formal authority that you do now, and you did it over time, but to start turning that practice around and changing a culture that had been there for a long, long time.
That's a great question. It's a very complicated answer. I'll try to summarize it, but I would say the biggest thing is leading by example, showing up every day, being here first, leaving last, bringing the energy. When you walk through that door, if you're slouched, if you're not happy to be there, that's going to rub off on everybody else too, right? And I felt like when I started here, that was kind of what it was. It was a clock in, clock out type thing. And so what we tried to do is change that to where people have a lot of pride in what they do, and to make sure that each staff member understands that they're an integral part of this machine. And without them performing at their very best, we as physicians and APPs cannot. So once we kind of empowered them and helped them understand how important their jobs were and how much their attention to detail really mattered, things started to change a little bit. And then most importantly is you can't ever ask anyone to do something you're not willing to do yourself. So we have somebody out, whether it's for vacation or if it's because they're ill or anything like that, we jump in. Everybody does. I'll transport patients. I will start IVs. I will do everything I can to make sure that the machine keeps going during the day. And when everyone sees that you're doing that, they don't feel good about sitting around, right? It's kind of like your grandmother. When your grandmother's up washing her dishes, you're not going to sit on the couch and keep watching TV, right? You get up and help her. And I feel like it's kind of the same thing. Once you have that mutual respect and people want to work with you instead of for you, things start to get a lot easier. But in order for me to do that, I had to come to you. If you remember, I had a lot of trouble, because the previous docs that were here for a long time. And one was the medical director for a very long time. And my philosophy was very different than his. And I had a lot of trouble trying to get things changed. So you guys put me in a position of power, right? You made me the director of operations. And that was a big catalyst. I think one, because there was an official position, but two, I think because DxTx recognized that I could bring that value. I think that helped a lot of people here too, saying, okay, well, they've recognized this, so let's give it a shot and see what happens. And then success is very important, right? Winning solves a lot of problems, as we say. So as that snowball started to run the right way and get bigger for the right reasons, that momentum has carried us. And, we have things that we have to touch up on all the time. And that's a part of it too, is daily vigilance. There are things that slip, right? Things that you think are fixed that we've had to go back and readdress. But those touch points are very important. So once you change a culture, then you've got to maintain it, right? And that includes bringing on new staff. So the first thing we talk about with our APPs or MAs or nurses or providers is that the one thing you can't do when you come in is break the culture, right? So if this is not a fit for you, that's okay. There's a fit for everyone in every practice, but we're looking for the people that work the way we do. And I think staff has recognized that as well. And if they have a concern about someone we brought in, they bring it to us. And then we can kind of nip that in the bud very quickly and address it with the new person or have a meeting with everybody. And most of the time it's a misunderstanding, right? You don't know that person yet and all of that. So we're able to work through those things. But if you're not receptive to information, especially complaints, and they don't get to you, then you don't know what the problems are. And that's when things really start to fester under the surface. And then 6 months from now, you have a really big problem that you can't fix. So that vigilance on a daily basis is very important.
You can feel it when because I've walked into APAC in both periods and, before and after, and you can really feel that energy and that culture and that vibe there. One of the things that I noticed you guys do like really consistently is you guys celebrate wins and you guys catch things and recognize things that go well. And that goes a long way in practices. But there's a lot of like celebrating of milestones and, being a recognized, top place to be in your area and a destination of choice for people. So just congrats on that. Expand on that just a little bit, not just for APAC, but, as your role as Chief Clinical Officer throughout the entire DxTx network. What role does the physician have, either with explicit authority or not, but what role does the physician have in setting the tone and the culture for a practice?
I think that's everything. I think that is outside of taking care of patients, that's our primary responsibility. We are the face because we're the ones that see the patients, right? We are the ones that go out and meet the other doctors for the referral sources. And again, it's like any other company or business or sandwich shop, right? The culture is set by whoever is in charge, right? And as medical director or as physician or as APP in your space, you're in charge while you're there for that 4 hours or 8 hours or whatever it may be. So you cannot, in my opinion, expect a practice to run better than what you show it should run or how it should run.
I couldn't agree more. It's one of the things that hearing that from physician to physician, you and Dr. Geith sharing that, because I go out and observe and have been to, hundreds of practices over the years. And sometimes you'll see the physician where they walk in, they see the patient, they walk into the procedure and they walk back to their office. And there's not that setting of the culture. So it's really great, seeing you guys do that.
I was really happy to do this podcast today because I don't get to sit in my office. This is nice.
That's true. That's true. One of the things that I know you put just a ton of effort in, I'd love for you to talk about, once again, that you see some things that I think feel maybe just instinctual or natural to you or certain leaders. is actually not. But one of the things that I noticed I'd like you to talk to is when you're bringing on a new APP or a new physician and bringing them in the practice, walk a little bit in the selection process and kind of what you're looking for. And then just as important as that onboarding. I've seen so many cases where, you have a very experienced or very established practice and the young physician will come in and they'll kind of like eat their young. They just it's not a nurturing thing for the physician. Even in a positive culture that sometimes they'll flail, let's say with an APP. What's your process on that between the selection and the onboarding of an APP or physician?
Sure. I'll start from the beginning with selection. About a year and a half ago, we stopped doing interviews for APPs and for physicians. We actually now have them come shadow in the OR for an entire day if they can, or as long as they possibly can, to actually see what we do. Because most people, a lot of physicians, a lot of APPs don't really know what we do. So interviewing for something that you don't really understand is a red flag for me. That's how you lose people in 3 months. The first NP that I hired, she was a former OR nurse in my old practice. So she'd been around pain for a long time. She graduated and called me and said, "Hey, I really want to, I finished my nurse practitioner training. I passed all my boards. I want to work in the pain space." She made it 7 days. It wasn't for her because the clinic side and the OR side are very different. Even though she had been in pain management as a nurse for a decade, she still didn't understand the differences on this side. So after that day, we just had them come and shadow. So the first step is to have them come observe, see if they are interested in this job, right? This is actually what we do. Your job is to make sure the patients, you identify the issues that they're having, you order a procedure that will help them so we can do that on this side. And that has been really helpful because we've had a few candidates too that came and said, "Oh, I didn't realize, I thought I was going to be refilling medications, or I thought this was going to be a lot of physical therapy referrals and I didn't realize how surgical it was." So that is really helpful in getting some more appropriate candidates to the table. Then we do the interview process and all of that. If they do come on board, it's a pretty rigorous first 6 months. And we do it for the APPs 100%, and we offer it to all the physicians as well, and hoping that they join the same program. The first 3 months is essentially being in the same room with me or my partner. And we see all the patients together, we discuss all the patients together, and they have a training manual that they are reading, memorizing, studying during their downtime. First one is the LCDs. That's the first piece of paper, or the first pieces of paper, because they're pretty extensive, that they get. And it's, go home and memorize this week. After you do that, then we'll start talking about clinical stuff. And once we get into that, we do that for 3 months. Then for the following 3 months, we're in clinic together, or I'm on the surgery center side while they're in clinic, and we're still discussing every case, whether that's before clinic starts, at lunch, or afterwards. So we're all on the same page. After that, then they are independent. However, I still do chart checks. Still want to make sure, what we're doing, what we're missing. And then every 3 months or so, that the patients that normally see the nurse practitioners will see me or Dr. Khan, my partner, just to make sure that we think everything is flowing the right way. Because like we talked about before, installing something up front is not enough. You have to monitor, right? And you have to continue to amend and teach and do all that stuff. That's a lifelong process. So the training, I guess, goes on forever, but that's how it's for us too, right? That's why we're going to Aspen next week to meet with all of our partners and thought leaders and get as much out of that as we can in 4 days. The field is rapidly changing. We know that, right? There's a big distinction between what pain management was in 1995 and what interventional pain is today. So that continuing education is very, very important. And then, like you said, we try to get together once a quarter at least, and we try to do it socially, and there shouldn't be any talk about patients and all of that, but that never really happens, right? We always end up talking about a case or something like that. But the camaraderie there is very important because the trust is very important, right? I need to make sure that everybody that works with us feels comfortable coming to me or Dr. Khan or Dr. Galperin when he's fully onboarded and being able to bring anything to us. And that working outside of the clinic time, I think that builds those bonds and makes communication much better. In terms of after all of that, there's not anything formal, right? So every 6 months we'll have a meeting, just everybody get on a call, let's discuss what we have there. But then daily we're doing this, right? every day we talk about a certain patient or a certain procedure or whatever it may be that somebody has a question on. Somebody didn't understand why we did this procedure for patient Y. And it's just a ongoing process.
I can tell you APAC is nailing it with APPs. I mean,
We've been very lucky.
it's rigorous but you guys are nailing it there. Can you just talk just from your philosophy, your personal philosophy on the role of the APP and how does that fit into your practice?
Well, I was very hesitant to work with APPs for a long time. And I think the reason was because how they were typically used in my region was just as med refill people. I just didn't really like that model. So what we've done, and I know what DxTx tries to do with all their practices, is to have the physician and the APPs work at the same level on the clinic side. Obviously, the OR side is different, but we teach them from day one that you guys should do the same things that we do. We're not going to give you a bunch of patients that are just med refills and then you go over here and do that. I will see patients just like they will see patients. And so they're expected to be able to identify and order the same types of procedures that we do. And I think they really appreciate that because they're not being used as a garbage bucket, for patients that we don't want to see. They're being utilized in the same way we would utilize a physician. So we've empowered them to make all the same decisions that we do with our oversight, of course. And I think they appreciate that a lot. And I think that's one of the reasons that they're so happy to learn and to try to do more and try to identify advanced procedures and try to improve patient outcomes is because we treat them the same way we treat an MD or a DO. And we have the same expectations.
Love seeing people functioning at the top of their license. So it's a term we use a lot, but I really believe that. And it's great to see our leaders fostering that. Kind of shifting gears just a little bit, talk a little bit about what you're seeing nationally in interventional pain management. Like, where do you overall kind of see things going? What challenges do you see out there that we have to stay ahead of the curve with? Any potential changes or not over maybe the next 3 to 5 years?
That's a loaded question, Mike. There's a lot of things I think that are changing, and part of it is market forces. For instance, with anesthesia being short everywhere, the anesthesia contracts and the locums fees for anesthesiologists has gone through the roof. So we're competing with those kinds of salaries in order to recruit great physicians, which is challenging. That's one of the reasons we've also started to incorporate more APPs, great APPs, not just any APPs, and elevate them to work as we work. I don't know how that's going to work out. At some point, there's so many people going into anesthesia that the pendulum will shift the other way. And I think in the long run, these lack of anesthesia trained pain fellows that are coming out, that'll change. And then we'll probably have to adjust again. And maybe it'll be easier for us to bring on more talent, more providers, more physicians, things like that. But in the short run, like we said, we're just empowering our APPs. We have good ones. We have great ones all across the network, and they're just looking for a chance. And you give them the chance, most of them are going to meet that mark if you give them the right tools, right? So that's our responsibility. And in fact, our newest APP, she came from the OB world. No experience in musculoskeletal anything or clinical care or anything like that. And one of the conversations that I had with her at the very beginning, I told her, if you're not good at this, that's not your fault. That's my fault. Right? We need to train you guys. So if you give them the right tools and you have the right people, they're going to come through for you, but you've got to be there to support them. But bigger than that is just the specialty itself, right? Every day, everything gets smaller, microchips, surgical equipment, everything. And so everything's becoming more minimally invasive. This is very, very similar to what cardiology and cardiothoracic surgery went through 25 years ago. If you had any cardiac issues in the 80s, they were cracking open your chest, right? I know and so then now if you need something done, a lot of times they're going through the groin. The cardiologists are just taking care of that, right? And the patient recovers in 4 hours and then they go home versus being in the ICU and all of that. We're seeing the same thing, right? There are tools available now for us to do minimally invasive things that don't require open surgical intervention, right? And general anesthesia, most importantly, probably. And so we've got to find a way, just like cardiology and CT surgery found a way to work together. We've got to find a way to work together with our surgical colleagues. And we're seeing that a lot now. It's getting exciting because there are a lot of orthopedists. We went with one recently who that is their vision. It's to bring surgeons and interventionalists kind of to the middle. So we're all working together. We all want great outcomes without complications, right? And we all follow algorithms and guidelines, but we do them independently, right? Interventional pain has its own set, and neurosurgery or orthospine, they have their own set. So that's, I think, the future, is getting us all to work together to create algorithms where we support each other instead of compete with each other.
What do you think is the kind of top one or two reasons that are contributing to maybe some dissatisfaction with interventional pain physicians or burnout? What do you think are factors that are contributing to that, and what can we do about it?
So that's a great question. I would say a lot of that falls on the insurance side, prior authorization, denials, and not denials because we didn't follow the guidelines and the policies. We're getting denials that are very random. They're moving the goalposts all the time. CMS says you cannot do a procedure if a patient doesn't have 4 out of 10 pain. I got a denial last week because a patient had a 6 out of 10 pain, and Carelon is requiring for some Blue Cross patients that they have 8 out of 10 pain. That's not written anywhere. It's just something they decided. So that's very difficult, because then we have to tell the patients, right? I'm sorry, you're going to be in pain for longer. This got denied. Now we have to appeal it. And that wears on the patients, which ultimately wears on us, right? We're here to help them. And when we can't help them for things that are outside of our control, that's really difficult. And the other is just staffing, right? That's in anything, finding the right people. People move, people retire, trying to fill those gaps. That is difficult. Luckily, we have great administrators here. Our administrator, Lauren, she's phenomenal. She's on top of all of this stuff, which really decreases my burden in having to deal with a lot of that stuff. But the main thing is insurance reimbursements decreasing despite inflation going through the roof, and the insurance denials. And that's another reason why, instead of fighting with each other like we're taught to do from pre-medical school, we need to collaborate. If you look at the nurses, they're so organized. The processes are a lot easier for them than they are for us, even state licensing or credentialing or any of that. And it's because they have a unified voice, and we don't have that yet. And that's one of the things we're trying to build, right?
Yeah. Yeah, I think one of the things that we can do, even from the DxTx, is uniting our people, getting, some common voices and some leaders to go out there and kind of fight that fight. And it's great to see. But definitely challenges out there. Any solution outside of like just advocacy, any solutions you see through technology that will be helpful to physicians as we go forward? I can tell you, at the last conference I was at was the Becker's conference in Chicago. And, even a year or two ago, you'd maybe randomly see a little bit of AI stuff. Now, probably half the people there and people requesting meetings with all these different AI companies. Do you see a future where that's going to complicate or relieve some of the pressure for physicians?
A really good question, because I think it's a double-edged sword. This is kind of like electronic charting to me, obviously much more advanced, but the problems that came with electronic charting, there are going to be issues like that, I think, with AI. One thing I didn't mention when you asked about physician burnout, which I should have, is documentation, right? And that kind of goes with the insurance denials and all of that. If I don't have to spend 5 to 10 minutes per patient documenting something, I think that's going to be phenomenal. At the same time, how do I feel about someone or something listening to the conversation I have with the patient to transcribe it in their own words? I don't know how I feel about that yet, right? But 10 years ago, I was the first person to say, I'll never get in an Uber, right? I'll never get in someone else's car. I need that yellow paint and it to say taxi on the side to make me feel safe, right? And I don't know the last time I got in a taxi now. I just always get in an Uber. So I'm sure that there will be a little bit of a transition period and getting familiar and comfortable with it and working out ways where the safety protocols are there. I also think there's going to be several companies, or a few companies maybe, that really separate themselves with true AI. I feel like AI is a buzzword, right? And it's very easy to garner attention. And we've talked about this before, but whenever we've talked to these AI companies, the first question I always ask is, well, what makes this AI? Well, why is this not just software? And rarely do we get a good answer. And when we get a good answer, then we get kind of excited about it and we say, okay, let's see what these guys are all about. So their products have to be true AI, and then we have to get comfortable with it and figure out how it works for us. But obviously, I know we have some people in our network working very hard on that. So I'm excited to see what comes out of it.
We're probably looking at more than a dozen different platforms for different support systems that we have at DxTx. Really interesting. Back to you. I know you have a really young family. You work tremendously hard, see a ton of patients, and are running a very successful practice. When you're not there doing that, how does Sheel Patel kind of recharge, fill the cup, keep that energy? What are your hobbies? What do you do outside of work?
I used to have hobbies until about 3 years ago when my son was born. He is my hobby now. I have a 3-month-old daughter as well. So when I'm not here, I'm, I'm taking care of them, playing with them, just trying to spend as much time as I can with them because I know everyone told me when Makai was born 3 years ago that it goes really fast, and nobody was lying. And so that's where I try to spend most of my time. You can see I'm a pretty big college football fan as well. Just sports in general. Try to get out in the 3 or 4 months where we have in Chicago, where the weather is nice enough to be outside. Try to get out and play some tennis. So just stay active, because if you're not taking care of your instruments, you can't do anything during the day, right? The energy just isn't there.
Prediction for University of Michigan football record this fall?
How many games are we playing now? I don't even know anymore. They
12?
keep changing it
12 or 13?
in the regular season.
Yeah.
I'll say this. I think we lose 3 games. I don't know what that'll end up being, but I think we lose three. I think
Will
two will
one,
be warranted and one will be a really bad one with a freshman quarterback.
will one of them be Ohio State?
No,
No. All right.
no, we're done losing there.
All right. Go blue. Dr. Patel, thank you so much for joining us, sharing your insights for the people within our network and people in the interventional pain space that will see this. Appreciate it.
No, of course. Happy to come on anytime. Thank you,
All
Mike.
right. Thank you.